Hi there. Good afternoon, everybody, and thank you for joining us. My name is Sally Guy. I'm the Director of Policy here at the Canadian Association of Social Workers. And I'm very happy to welcome you all to the second part of this webinar series, which is titled Client-Centered Mental Health and Addictions Systems, that is being presented in collaboration between the Nova Scotia College of Social Workers and us at the Canadian Association of Social Workers. So we do have hundreds of social workers tuning in today, and we're honored again to have Todd Leader presenting for us. So for those of you who missed part one, Todd is a registered psychologist and a registered social worker, and he spent the last 26 years leading service development and transformation, as well as working in health promotion, particularly in the areas of mental health, addictions, and primary health care. So as for process, the first half of the webinar, approximately half an hour, will be a presentation by Todd. That will be followed by a half-hour question period that I will be moderating. So at any time during the webinar, you can type in and send your questions, and I will begin asking those at the end of Todd's presentation. Also, of course, happy to note that a recording of this webinar, as well as the PDF of the presentation itself, will be posted on the CSW website, as well as on our YouTube channel. So with that said, it's my great pleasure to welcome Todd.
Hi, everybody. Glad to be here again. Looking forward to doing this, and thanks to everybody for jumping on board. So let's get started right into it. So this part two is, part one, for those of you who were around, was actually about defining the concept of a system that's client-centered as opposed to care that's client-centered. This part two is going to be specifically about moving from what I refer to as our mental illness care system to what we should have as a mental health system. And of course, that's the name that we call it now. We call it mental health and addiction system or mental health system. But as you'll see as we go through, we're clearly not doing what we should be doing in order to justify that name. And there are ways to make that change if we have enough people wanting to make that change. And so here we go. So this is a refresher from the last session. I want to start with this because it's an important concept. When we use the term client-centered, what that really means is, and we take this for granted, what it means is the client is the priority. It's not a priority, it's the priority, because the word priority, the root of it is prior, which means it's a term of relativity. And so if you're saying the client is at the center or the client is the priority, that means the best interests of the client must come prior to other considerations, like money and politics and union preferences and staff preferences and administrative habits and all of those other things. The client's needs should come prior to those interests, or we're not really client-centered. So that's an important fundamental concept, and you'll see why as we move along. So for a system to be client-centered, and as opposed to treatment, so treatment itself, and just to be clear, treatment itself is client-centered if we apply the kinds of principles of compassion and empathy and letting the client be the guide and the expert on him or herself, and some of those Rogerian things. But for a system to be client-centered, it's a little bit more ambiguous because we have to know who the client actually is. Who is the client of the system? Now, in a private practice, that's clear. If you're running a private practice, the client is the person who actually calls and gets an appointment, who seeks your service. So your clients, plural, are that group of people who you are serving. But when we're talking about a public service, like our public mental health and addiction systems, when we're talking about those, it isn't that clear because technically speaking, the public is in fact the client, the whole public, not just the people who show up at the door. It's a public service. So, in each province, our Department of Highways, for instance, who are they serving? Well, they're serving the whole public, not just people who own a car, but everybody who ends up even needing an ambulance or something or a truck to be able to ship something to the community that you live in. That's serving you. So it serves the whole public. So a public mental health and addiction system, the taxpayers, the entire population, is in fact the client. It's not only those who come in. So the bottom line is that the service itself is supposed to be serving all those people who are healthy, who are ill, who have minor ailments, etc., because they are, in fact, the client. This is a really important kind of concept because right now what we have, take a look at the system in your own area of the country and think about who it actually serves. You're going to find that it serves the people who are the most ill and are in crisis. So how does that work? Well, the way it works is that somebody calls to get an appointment, and when they call, they get triaged to some extent, whether that's formal or informal. There is a triage kind of a process that happens in many areas that tries to judge urgency, and the people who have the most urgent or the most severe illnesses, of course, get in earlier, and the others don't. In fact, some may be redirected elsewhere, and some may be put on a wait list or given a wait time that is, potentially months or even beyond a year in some areas. And so in order to actually become a client of the system, in order to realistically get access to the system, you actually have to have symptoms that are severe enough to qualify for treatment. It's like there's a line there, and if you're below that line in terms of the symptoms you have, then you're really not going to get realistic access. I mean, if you call for an appointment and you end up being given an appointment for 7 months from now, or we got one area in Nova Scotia that's got it's over a year, I believe now, and so if you get that kind of appointment, it's really easy to argue that you in fact are not a client of that system, because that's not being taken into the system. That's not being provided with service. It's so far away that it's almost non-existent. And so you have to be severe enough to qualify for treatment in our system. So that's who it currently serves. Now, again, going back to the private practice side of things, if any of you are in private practice, anybody who comes to you, regardless of their condition, regardless of the severity of their issues, regardless of any of that, that person is likely going to become your client, and not in any different way than any other clients. So that makes a distinction between public and private that is important. So who do we not serve? Who does our system currently not serve? Well, it doesn't serve people who are healthy, because of course that would sound absurd. Right? The idea of a system that's made to treat mental illness, it's absurd for us to think about people who have full health, who are fully healthy. And so our system does not actually do systematic, evidence-based things and provide service for the healthy population in order to keep them healthy. So anyone who's healthy is not actually being served by our supposed mental health system. Even though we use that term. But we don't do anything to maintain mental health with those who have it. So we also don't serve those who have mild or very early symptoms of what might in future be a mental illness. Again, we don't keep them from becoming worse, because those are the people I just described a few minutes ago who may be calling without any real illness yet, but they're having some concerns. So that might be, for instance, I might be experiencing some sadness that's lasting a little bit longer than normal and starting to bother me. And, whether it qualifies as depression or not in terms of diagnostics, well, I'm not really sure, but it probably, at this point, it's just that it's bothering me, and I think I probably should get someone to talk to about it so that it doesn't get worse, so I don't end up with a diagnosis of a chronic illness like depression, and I don't end up needing medication, perhaps, and I might want to do things right now to get it fixed early, and we're used to this concept in the rest of our system because we have things happening that do this in the rest of the health system, despite how much criticism the public has of the rest of our health system. The fact is that if you go to your doctor, if you go anywhere and you get, say, your blood pressure checked, and your pressure is still in the okay range, but it's really starting to creep up a tiny bit, well, your doctor is not going to say, well, this isn't bad enough yet, so, we're not going to do anything. There's no change needed. It's not bad enough to do anything about. I'll make an appointment for you for 8 months from now, and we'll see what it's like at that point. That's not going to happen, and that would be a ridiculous thing. Or if you got your blood glucose checked and your A1C, which is an indicator of a 3-month average, that A1C was up a little bit higher than the normal range. Nobody's going to say at all, well, let's make an appointment for you at the diabetic clinic 8 or 10 months from now, because it's probably going to get worse. Nobody's going to say that. They're going to actually start to talk about lifestyle changes that will prevent these early symptoms from becoming chronic illnesses. They're going to be recommending eating differently and dropping salt, and depending on the issue, eating less carb if it's your glucose levels, and exercising more and losing weight, and they might even require you to come back in a few weeks to check again, and you might get medication right off the bat to get things under control. But the idea is that mild and early symptoms are treated seriously, because we should be providing care that helps keep those symptoms from becoming worse, from becoming chronic illnesses that then become, even coming at it from an administrative perspective, that then become a burden on the system that cannot handle the demand that it has now in the mental health side of things. Oh, an error occurred. Hang on one second. I've got a technical problem here. I don't know what it is. Oh, no. Sorry, hang on, folks.
Thanks for hanging in on the line there, folks. We're just going to make sure that Todd's connection is in order here.
Yeah, sorry. I just have to pull out and back in because my internet just crashed on me a second.
All right. The absolute joys of technology, friend and foe. Thanks for your patience,
Should be
everyone.
almost there now. Just 1 second.
Some of you had noted, too, in the Q&A section already, just wondering about that certificate of completion. So like usual, if you attend 45 minutes or more of this presentation, you will have access to that certificate of completion that will appear as a yellow icon at the bottom of your presentation window. So once again, yeah, we are offering that certificate of completion for those of you that need that for their continuing education hours.
And I'm back. So what I've just described really is a system that's exclusive rather than inclusive. We have unwritten or sometimes written or unstated or sometimes stated exclusion criteria that decides or defines the line between who the system will provide service to and who it will not provide service to. And I'm not suggesting at all that the people in the system are intentionally trying to discriminate based on level of illness. I'm not suggesting that anybody's doing anything wrong, especially not the clinicians. None of what I talk about has anything to do with the clinicians doing anything wrong. So it's about the system itself. And by the nature of what I just described in terms of who ends up getting seen, if you're too healthy, you don't get seen. That's really exclusion criteria. That's a line drawn in the sand. And so anybody that is excluded as being not serious enough, really what they're asked to do is wait. You're given an 8-month appointment or longer because it's not serious enough. So what you're being told to do is wait. And what do we know happens when anybody with any kind of substance use problem, with virtually all mental illnesses, anybody who has early symptoms, what happens if they just wait? Well, we know what happens. It's the same as what would happen if my blood pressure was starting to creep up or my blood glucose level. It's the same thing. It's going to get worse. Most mental illnesses, and certainly substance use and addiction, are the same as many physical illnesses in the sense that they're progressive. If untreated, if unmanaged, then they will progress and get worse. And so then you'll end up qualifying for help. That's the great part about having a wait time that's 8 or 10 months away or 6 months or 5 months, is that it guarantees that eventually you're going to qualify and meet the inclusion criteria of the program, because you will get worse and you will then end up with a shorter appointment time eventually. And I'm not trying to be dismissive of that or take that lightly. I'm saying that that's the reality of it. That's what we see happening all the time. We see people who try to access our services either at a hospital or an outpatient center, and they end up not getting in quickly enough, and their condition gets worse. And then we end up reading about their stories, a year later about suicide attempts and people dying by suicide. And when, in fact, if we had caught them early enough, we may have actually made a difference. And so there's proof of this point that I'm making, that the system itself, it views itself, and I know I'm kind of animating a system here, but it views itself as being there specifically for treating mental illness, not for ensuring mental health, not for supporting people to prevent mental illness. And on Amazon, where my book is, one of the places my book is, people can post reviews and comments, that kind of thing on what they thought of the book. And one of the people who had said some critical things of it, I was fascinated by this, because I was fascinated by the fact that the comment actually, even though the person was trying to trash the book, the comment actually supported exactly what I was saying, but that person doesn't seem to realize it, so I laughed pretty hard. And here's what the quote was. Mr. Leader's model would be useful in a counseling center, but not in a Nova Scotia public mental health and addiction service, which has a mandate and a primary focus to treat serious mental illness and addictions. That's it. That is the statement of exclusion criteria that I'm talking about. That is the proof that this is the way the system sees itself. It sees itself as drawing a line in the sand, and if you're not sick enough, then we're going to wait until you are sick enough and then provide you with help. And again, that's certainly not because of the clinical staff being unwilling to see people earlier in the course of their potential disease or disorder evolution. Most clinicians and certainly social workers would generally far rather see people earlier and prevent illness and help them learn to manage the early symptoms, and actually look at focusing on health, not just on correcting illness. But this particular statement demonstrates that that's not the way the system is structured and designed. It's not the way it sees itself, and it's certainly not the way it functions. So we don't have a mental health system. We have a mental illness care system, and this clinician from somewhere in Nova Scotia has stated that explicitly. So what we don't have is the promotion or maintenance of mental health. We don't have a system that keeps healthy people healthy. It waits until people are ill. And so we need to either start to change our language and start to call it a mental illness system, a mental illness care system. We don't have a problem referring to our health system as a health care system. Lots of people talk about the health care system because that's really a more accurate recognition, I guess, of what the majority of the work is that's done in that system. So maybe we need to change our terminology and call it a mental illness system. Or we need to start to look at what do we have to do differently in order to turn it into a mental health system. Now, some of you may know this slide. You may have seen this. If you're familiar with Brian Rush, he was with the Center for Addiction and Mental Health for many years. I believe he's retired now. But he developed this tiered model, and I think with some other people. But he developed this tiered model that actually tries to estimate and then serve properly the numbers of people experiencing the various levels of health or illness on a continuum. And so the top three, I mean, if you look at the very top tier, that top tier is essentially the work of psychiatry. That is the top specialty. That is the most intensive, most complex treatment that there is. That is medical psychiatric intervention. Tiers 4 and then Tier 3, those are, for the most part, those are the kinds of activities that are provided by clinical therapists of various professions. So they might be clinical social workers, they might be clinical psychologists, other forms of registered therapists that vary from one province to another. So most of Tier 3 and Tier 4 is really like psychotherapeutic kinds of interventions for people who already have illness. Now, if you look at Tier 2, they're the people that I mentioned who have some early kind of symptoms but actually don't have an illness. They aren't diagnosable. They don't actually have a mental health disorder. They might actually have some early substance use that's starting to interfere a bit with their lives, but it wouldn't be considered an addiction at this point. They're capable of stopping. And so those people are the people that I refer to as not qualifying. And then the bottom tier are all the people who are completely healthy. These are the people who have no mental illness, even symptoms, no substance use difficulties whatsoever. Many of these people would be using very little of anything, including alcohol. They'd be having truly the occasional drink. These are people who would have normal sadness when sad things happen, but are experiencing nothing that they would ever wonder about as being depression. They're not hearing voices. They're not having anxiety any more than normal. These are healthy people. And our system obviously does nothing in a structured way to actually promote and maintain the health of purely healthy people, of entirely healthy people. So it's those bottom two tiers that we're missing in our system. And if our job is to serve the client, and as I've defined it, the client of a public service is the whole public. It's not just those people at those top three tiers who come to the door. It's the bottom two tiers as well. In fact, by numbers, statistically speaking, the majority of our population, in fact, is in the bottom two tiers. That's why this diagram is pyramidal. That's why it's in that shape, because the fewest people we have are actually in that top tier. In other words, the smallest number of people in our population are the ones who need intensive psychiatric intervention. And then there are more who need psychotherapeutic intervention. And then the majority of people actually need just to be supported in some way to promote or maintain their existing health. And so, what do the bottom two tiers actually look like? Well, let's look at the Tier 2, really. What we're talking about there is supportive counseling that is not therapy. This is an important distinction, and lots of people use these terms in different ways, so I've got to be clear about how I mean this. Therapy is a structured process to some extent. Therapy includes the use of established structured, manualized methods in many cases. It includes exploration of deeper kinds of concepts, of historical problems, family of origin problems that are complex and contributing maybe in unconscious ways. Therapy is more in depth and focused on the correction of problems that are beginning or already exist. Counseling, the way I'm describing it, is literally as the word implies. It's providing somebody with support and advice. It's providing somebody with potentially with skill development. For instance, so you've got a 14-year-old boy whose girlfriend broke up with him, and he's feeling more sadness than usual, and he's distracted from his schoolwork, and he needs some help. Well, he doesn't need psychotherapy because he doesn't yet have depression. He's an adolescent, and he's experiencing something known as adolescence. And so what does he need? He needs skill development. He needs to be able to understand what sadness is and how to manage that. not eliminate it, but how to understand it and manage it. And anxiety, people with anxiety issues, simple stress management and anxiety management, maybe some mindfulness-related kinds of things. There are lots of things that can be done for people who are not ill but are experiencing symptoms and just need skill development. So it's non-therapeutic. And this is an important term, it's not pathology-oriented. When I talk about counseling, it's not pathology-oriented, whereas therapy generally is. Psychotherapy is designed to assess, diagnose, and treat pathology or a disorder, something that's diagnosable, a substance use disorder, substance abuse, substance dependence disorder, all of those things. And so it's meant to be the same as what we would do with people who have physical illnesses, where we support them making changes. We support them learning new skills so that their early symptoms don't change, don't continue to get worse. Now, if we look at the bottom tier, the very bottom one, what we're talking about there is truly the definition of health promotion. And so health promotion, just to be clear, health promotion is not necessarily the same as health education. Health education can be a part of health promotion. But health promotion, its number one tool in health promotion is actually advocating for public policy change. It's advocating for things like regulation of the industries that provide the substances that are responsible for our substance use and addiction problems. It's regulating those industries. There's a ton of international evidence that tells us exactly what to do if we want to reduce the problems we have with these issues. Now, that's a challenge for us. We've been very successful with tobacco, and it's not because of educating people. It's because of making it harder for kids to get access to it. It's about increasing price. It's been about, we've had since the 80s, a restriction of no advertising. In alcohol, we've generally been, well, I think as a country we've been a failure at this because we really do very little to regulate the alcohol industry itself. They're allowed to advertise to our kids, and they do. They place advertisements during television shows when our kids are watching. They blow up their large inflatable beer can at the local community festival. We have a ton of that stuff that we know actually causes kids to use earlier and to use more when they start using. And so, there's a lot more we could be doing, but that's what Tier 1 at the bottom is. It's public policy work that actually will change the health of the next generation. Cannabis, well, what can we say about cannabis? We're doing the right thing by legalizing, but our government is not heading in the right direction in terms of how, because, and mainly, the biggest thing actually is that it's taking more of a corporate model that's about commercialization and profit than a public health model that's about protecting our young people, which is what the government promised to begin with. We're going to regulate cannabis, or we're going to legalize cannabis specifically to protect our kids. If that was the case, the age would be taken from the recommendations of all the national organizations of experts that have said 21 is it, when we know that developmentally 25 should be it. But that's not realistic politically. But everybody said 21. Our government's going the other way. If we want a healthy next population, if we want less depression, anxiety, and schizophrenia, especially schizophrenia in our young population, if we want less of that in the next generation, then there is a role for us all to advocate for public policy changes during this year before that legislation is set. People need to know exactly that we're ethically making a major mistake here if we do this wrong, and if we allow kids the age of 18 and 19 and 20 to be able to use cannabis legally and regularly. So this public policy stuff, we're also talking about more private policy, and that would be in the form of healthy workplace policies. So we have healthy workplace legislation in most provinces, but there's not as much focus on psychological health in the workplaces. And so that involves actually being really clear in policy and in management about how to manage to keep people safe from bullying or harassment, sexual harassment, those types of things. And so there's lots that our mental health system should be doing to be out there being the messengers, being the ones pushing for really tight regulation and training and the things that are needed to make sure that nobody experiences those problems at the workplace, and that their own mental illnesses that they may have are accommodated in the right way at the workplace. Psychologically healthy schools. Well, that includes a number of things, but it's the same as the workplaces in most ways. But I'm going a step further with this, and that is that if we had a mental health system, if it was about health, then we would be making sure that the curriculum in our elementary schools across the entire country would have social and emotional learning curriculum built in, embedded in the school. One example of such a program, the one that has the most evidence behind it, is PATHS, which stands for Promoting Alternative Thinking Strategies, and it's on the market, available. I don't get a commission, by the way, in case you were wondering. But PATHS is a social and emotional learning program. It gets implemented across the entire school so that the training, in fact, is for everybody. The bus driver, the principal, the custodians, all the teachers, everybody learns the language that has to do with really a lot of emotional intelligence kinds of things. But the key thing about this approach is that it has preventative effects. It actually reduces the rates of mental illness and addiction and bullying or aggressive kind of behavior. It prevents those. It reduces the numbers, and it improves school performance. So, this is about how do we create a mentally healthy next generation. How do we take kids who are healthy now and just as part of their regular daily school, do things that will actually make them stay healthy. And so there are ways to deal with that tier 2, or tier 1, I mean. So what can each of us do is, I guess, one of the key questions. And one is, as a private citizen, we can all advocate for the public policy kinds of issues that I just talked about. Advocate for the control of substances, advocate for legislation that is tougher on the provision of environments in workplaces and schools that actually make people healthy, psychologically speaking, because that's the part we ignore the most. So we can advocate for that in our own workplaces. We can become volunteers in our own workplaces to help build those psychologically healthy kinds of factors in. And there's lots of information. The Canadian Occupational Health and Safety Association, I think it's called. There's good information there about what it is that's needed for a psychologically healthy workplace, so we can all do that. But advocating for public policy change around many of these kinds of issues, and I know that's foreign language to a group of social workers, but it is critical. This is why I firmly believe, I really do, that the greatest potential for making a difference in the health outcomes, the mental health outcomes of our next generation, the greatest potential, I believe, exists in the profession of social work. I believe that you all, that this group, that this organization, that this collection of how many thousand across the country, 18,000 members of CASW, I believe this profession is the one that has the greatest power to change the future. Just because this group has learned two key things. One is to get rid of your own assumptions and critically analyze the system around us and those systemic kinds of issues that cause wellness or illness or discrimination or oppression. So you've got the skills to do that. But secondly, the skills to advocate. The skills, the desire, the passion, and the courage to advocate for those systemic changes so that things do actually change. And this is a profession that grew up with that passion, that intolerance of injustice and intolerance of ill health. And so as a parent, you can advocate for programs like the PATHS program. If you're a manager or a director, you can start reallocating some staffing. You get a vacant position, start to think about how can we start to provide an early intervention service, particularly to young people, to adolescents, by hiring somebody who's trained as a counselor, not a therapist. So we need to make the system serve the whole public, not just the people who qualify, not the people who have waited to become ill enough we need to actually start to focus. If we want a mental health system, we need to put the health back into it and focus on those bottom two tiers. And I'm not saying take away psychiatry and psychology and clinical social work. I'm saying we need to add the rest of this work into the mandate of our systems and not leave it to community organizations to do, because they're the only ones who are doing it now, who are advocating for that health end of the continuum. So let's keep healthy people healthy. And back to you, Sally.
Well, Todd, thank you so much for that really thoughtful presentation. I think inspiring in some places too. It's, of course, now time to get to the audience questions. So a note on that for process, I am going to do my best to get to all the questions, and I will be also trying to keep them themed together, just so I can get to as many as possible. But thank you in advance for understanding if we don't end up making it to yours due to time constraints. So one thing I noted during this in terms of the questions that are coming in is that a lot of people have put in sort of, I would say, thoughtful comments. So a lot of people there's a lot of response in the question section here in terms of sort of rhetorical questions and thoughts on this. I'm going to start with one about your thoughts on exclusion, Todd. So this is the comment here. I wanted to comment on your thoughts on exclusion. I oversee a collaborative program that has brought together government, the community, and our health authority. We have improved our system's response for people with complex needs in St. John's. When we talk about exclusion, we need to consider both our systems in terms of policies, etc., but also some of the biases and attitudes on behalf of workers that can end up excluding people from services. We need to name this when it occurs and offer training or education, etc., to those who sometimes exclude people who we need to include. Do you have any thoughts on that?
Absolutely, it's a great observation. So when I talk about a system, I'm talking mostly about the sort of the status quo of how things work. It's the processes, it's the administrative stuff, and all of those things. But all of the staff, all of the managers in multiple agencies, not just the formal mental health and addiction program, so in the partnership that was just described, all of those staff and managers and directors, they all play a role in either sustaining or changing that status quo and that exclusionary kind of system that exists. And I said this in the last session, but I'm going to repeat it because it's really important, but I'll do it briefly, and that is that what happens, when somebody is hired into a system as a clinician or as a manager or as anything, you assimilate to what the job already is. Somebody trains you and tells you how they want you to do the job. And so you begin to do the job that way. And so the status quo gets maintained by default. And so many of the attitudes that individual staff may have that are exclusionary, some of those would have been actually adopted as part of their training and their assimilation into that system. But having said that, you will also obviously will always find a few people in every system, in every organization, who in fact just by personality are going to be what I call the work avoiders, or whose own biases or prejudice is going to affect them. And I've seen within a mental health and addiction program, I've seen prejudice. We like to call it stigma these days, but it's not something new. It's just prejudice. But I've seen prejudice among staff against opioid clients, for instance, who are in a methadone program. So we have those kinds of problems everywhere, and all of that needs to change, and we all need to start to address that. And I agree with the comment, you need to name it when it's happening and address it. And that's one of the things, in management. Many people in management in the public sector, in a unionized environment, they avoid naming things and addressing them because every time you do, it becomes a long, drawn-out process with unions and all of that. But that's not a reason. That's not a reason to do what's right for the clients by addressing that inappropriate kind of behavior that's helping to keep it exclusionary.
So on the other side of that, I have another comment that's kind of addressing sort of the opposite side. So someone writes, I don't think the distinction between people working in the system and, quote, the system is useful. Political policies and directions, as well as people working in the system, do set up systems to exclude and include. Systems are run by people and they don't form themselves. Even though people don't intentionally set out to discriminate, the outcome is often discrimination and exclusion. What are the implications for change, then, of this distinction? How will change occur, led by whom? So just, I think, some frustration there on that side, too.
Yeah. Well, the thing is that a system, I'm sure that everybody's familiar with the concept of system theory and homeostasis and all. We know that systems themselves, that yes, they include people. Each of the people is a unit or a part of a system, but a system will maintain the status quo naturally. It does actually have almost this ability to exist on its own and to self-sustain. And in a public sector system, especially a unionized environment, especially one that's dictated by politics, in those kinds of settings, the status quo will likely stay unless there's active change by individuals who say, I'm not going to tolerate this, and it's time for us to change this. And I guarantee you, I promise you from my own experience, I can promise you that the people who start to say, we're going to make fundamental changes that put the clients before things like budgets and politics and convenient hours for us all as staff and all of those other things and union preferences, the people who start to say we're going to put ourselves and all of these other things second to the client, they're going to have a rough ride. This change is not easy to do. This transformation is not easy. But the more people there are starting to say we need to make these changes, the more likely it is that the system itself will start to shift. But it won't without decisive and explicit action.
Mm-hmm. A lot of people are typing in things about what sort of similar themes on what to do in an era of austerity, or what to do in an era of budget cutbacks in the social services and in mental health and addictions. And so there's a comment here. It's also kind of a question. I'm wondering if you wanted to maybe comment on it. Is, do you believe that changing the name of the system to mental illness care might be jarring enough for us to actually make a necessary change?
I think, I love it. I love it because it's
right?
a bold question, right? So I think that suggesting that we change it, I think if we were to start suggesting that we change it so that it reflects what we actually do, I think the suggestion itself would be met with a great deal of resistance and offense and debate. And so, yeah, there's value in that for sure. That's what I believe, because I believe in some of those things we just take for granted. If you ask, many of you, if you work in the system, but there are certainly many people at more senior levels in our organizations, if you ask them about this, they would not agree with a lot of the stuff that I've said. They would say, no, we have a mental health system because we do. We do mental illness education for our students. So what? So they know what depression is. Well, that's not actually promoting the health of those kids. That's just telling them information about certain illnesses. And so people would disagree with some of this. So, yeah, making bold statements like that, I love that. That's why I called my book "It's Not About Us." Because from inside the system, that's what I used to say. It's not about us. People would say, yeah, we can't make that change because, and they'd name all kinds of reasons, like money and all this stuff. And I would say, yeah, but it's not about us. So it doesn't matter. And that was seen as that same kind of almost confrontational type of thing that kind of shocked people back a little bit.
Yeah, no, I like bold statements like that, too. I think social workers are definitely pros at sort of creatively and ethically shaking up the system.
Absolutely.
So this kind of leads into that. So somebody says, we can't do it all. So, and then someone adds, in our area, our psychiatrists are overbooked with long wait lists. How are we supposed to justify putting these resources into prevention or early care while we're also dealing with that high demand?
Great question. I'm going to try not to take the next hour and a half to talk about this one question. But my simple answer to this, or my concise answer, I should say, I didn't mean that to sound patronizing about being simple about it, but the concise answer is that in many areas we have psychiatrists who are overbooked, who are overworked, but many of the people they're seeing are people who don't require psychiatry because their issue is not medical in nature. So one of the problems across many of our systems is that we're not using the right professions for the right jobs so that we're protecting the specific specialties for only the work that is meant for them. So if you go around the country, you'll probably find places where a psychiatrist is actually spending a half hour or an hour with a patient doing psychotherapy. Well, that's a waste of a lot of money. So coming at this strictly from an administrative perspective, that is not what we should be using a medical professional for. A psychiatrist's specialty, while they may have learned, some of them may have done extra work and really learned how to do some psychotherapy, the fact is that psychotherapy can be done by clinical social workers or clinical psychologists who are a third to a tenth of the cost of a psychiatrist, depending on where you go. So, in Nova Scotia, it's about a third of the cost. So we could have 3 people doing psychotherapy and keep those clients from getting to psychiatry unless there's a need for a medical kind of consultation for medication purposes. And so that's what one of our problems is. And the more we can kind of screen and place people appropriately for the kind of service they need. Someone who only needs counseling shouldn't be in with a therapist. Someone who only needs therapy shouldn't be in with a doctor, a medical doctor who's a specialist in psychiatry. But I don't think our systems are that good at making sure that we protect that time by placing people in the right service, the least intrusive, the lowest level of specialty necessary to provide for their needs. And that's where you free up time. That's where you free up money and resources to provide some of the lower-end interventions.
So someone, I think, is probably responding to that and is saying, so are you saying that we should be replacing therapists with lower-level counselors? I know that a lot of social workers, and I mean, I'm sure other professions are concerned about what we call profession creep, or the deprofessionalization of the profession. So I think that question is kind of coming from that place.
Oh, yeah. Okay, so I'm absolutely not suggesting that we need to have fewer clinical social workers and clinical psychologists and other types of trained therapists. I don't believe that's the case. I believe that in most areas we probably are closer to the right level of that. What we end up hearing a lot is a lot of cry for more psychiatry. That's one area where I say I think we're not always right about that one. So what I'm suggesting is that the amount of resource of any particular level of training and type of service should match the amount of demand for that particular type. So if we've got people who need therapy going to a psychiatrist, that's not a match. And so we need to find out how many really need psychiatry and provide that many psychiatrists, how many need psychotherapy, how many need clinical social workers. We need to get better at making sure the people we put there are the right ones. But then the people who don't need that could be served by somebody who's not actually trained to be a therapist. It might be a BSW. It still might be a social worker who has counseling training or has introductory therapeutic kind of training, but hasn't actually been trained at a master's level, which generally speaking, for most therapeutic positions, generally speaking, that's the minimum level. And so, I'm not at all saying we need to get rid of. I'm saying that there is a place for a lower level of training, and that might be a BSW, and there's a place for some paraprofessionals as well, where there's simply no need for that level. And so somebody with a community college training, counseling training program for 2 years, there are some jobs at the very bottom of that pyramid that could easily be served by people like that. And so I'm just saying we need to stay open for all of those things. But again, there's a lot more room for BSWs in our system than we actually have right now, because we've tended to have an elitist kind of approach where we only want to hire people with master's level in any field, and they have to be regulated professions, and et cetera, when in fact we can be doing more with people who aren't trained to be therapists, but who can do the lower level, earlier intervention.
I think that, there's a lot of comments coming up on this issue of resources and of how to best use them, I think. And so somebody writes a very thoughtful comment, and it does end with a question that says, so to put resources into keeping healthy people healthy, we either need more resources to do it, or, of course, we need to redirect resources from pulling people out of the river, as they say, which means that some people will drown, which, of course, is not acceptable. Part of what we need to do, I think, is to convince those who hold the purse strings to invest in those lower tiers. We do it right so infrequently, though, that it's hard to find empirical evidence for the cost-effectiveness of lower-tier interventions. Could you recommend resources or sources we can arm ourselves with when we advocate for these policy changes that are needed?
Sure. Well, I'll start actually with the health promotion kinds of stuff that I talked about. Starting with that, there is a ton of international evidence on the issues of public policy preventing addictions, for instance. There's the best book in the world on that one, if you want it, is and this may not be what you're asking, but I'm going to tell you the things I do know. The best book in the world is called Alcohol, No Ordinary Commodity. And it came out of CAMH. There's a second edition of it. It's the best summary of the policy changes that are needed in order to regulate. And there's a lot of stuff out there now on regulating cannabis as well through policy, but it's essentially almost all the same stuff that's in that book for alcohol. The PADS program, the social and emotional learning, if you just Google that stuff, you will find a ton of evidence that supports putting social and emotional learning resources into schools that will keep our kids from ever ending up having to be our clients. I don't have a resource right at the tip of my tongue right now on the value of early intervention, but I know it exists and I just can't place it. But I'll see if I can find something and send it off to Sally, who can potentially post it or put it in the next email going out or something like that.
For sure, and I've also been answering some questions to people directly on here that have been providing me with resources. So somebody provided a really good sort of rundown of that three-tier system, a snapshot of that. So anything like that and the book that you mentioned, I can post as resources right on our website under Continuing Education, just right underneath the link where you're going to be finding Todd's presentation and the recording of this webinar. So I can list those things there, no problem. Somebody adds to that there are more sort of, that sometimes lower tier interventions can also be more sort of holistic in nature. They're not necessarily therapeutic. So somebody adds that the Roots of Empathy program is an early intervention school-based program. It's delivered in elementary and middle school students' classrooms. The program helps to build empathy, explore emotions, and reduces bullying, and the students are to participate. So I don't know if you're familiar with that program. I know it's in the Atlantic provinces, and I think it has some good uptake.
Yeah, well, I'm not familiar specifically with that one, but the description of it tells me it's social and emotional learning, which is the key. And social and emotional learning basically is it's like emotional intelligence. It's learning to understand and recognize and manage your own emotions, and learning to recognize and understand and respond properly to other people's. And so, and that much of that is, in fact, by definition, empathy. So I don't know the evidence on that specific program, though, but that's the kind of stuff. And I agree that we're not as bound, in terms of early intervention work especially, we're not as bound to the therapeutic rigidity that exists for interventions where there is illness. And so there's a lot more room involved, where we may not have evidence for a certain kind of method as a therapeutic intervention. It may be perfectly effective for somebody who is healthy but starting to develop some anxiety challenges, but not a disorder, and just needs some methods of calming and relaxing and, mindfulness and other kinds of things. So there's more flexibility there.
Right. Another person added a comment actually at the very beginning, just venting some frustration. We've talked a lot about, resources and lack of access, but this is sort of more lack of access or a deterrent from access built into the system itself. So she says, unfortunately, a lot of the time when clients begin their journey for mental health services, they begin when they notice signs of concern. Then they are declined for mental health services, and then they are more reluctant to call back when signs are more severe. If they were seen when the signs began, it would have prevented them from spiraling into crisis and costing the system more time and money. This is so frustrating.
Yeah, absolutely. I'm sorry, I don't mean to laugh, but that is the core of the issue. That is the very core of this issue, is that we draw the line in the sand and say, sorry, we don't serve your kind here. You're too healthy for us, and so we cause the problems, because where that person is going to end up, and I'd be willing to bet anybody $100 on this, where that person is going to end up, because they will be hesitant to call back and be dismissed again, because making that call, as you can probably all imagine, and some of you may have had the experience personally yourself, but making that call to say, I think I'm having some mental health problems or some addiction-related problems, is probably the hardest phone call anybody ever has to make. So they're not going to repeat it if they've been dismissed. So what happens? Well, they wait. They get so bad, they continue to deny themselves the hell of making the call again, and where they're going to end up is the emergency department, the most expensive part of every part of our health system, the most expensive place for anybody to be seen, and clearly, from a client-centered perspective, the least appropriate place in the entire world for somebody with a mental illness to have to go.
Yeah. I think I'm going to combine two unrelated questions that sort of will make you talk about the same theme. So someone adds, you talked about our systems having these exclusion criteria, but isn't that necessary so the program is not overwhelmed with demand from people who don't really need that type of help right away? And then somebody also says, would you say that private systems can be more inclusive primarily because clients have the ability to pay?
Yeah. Okay, so what I would say is this. If we structure our public systems properly and we protect the types of services so that they are being used for the types of needs that come forward, so that's all that stuff I talked about with psychiatry dealing with only clients who need psychiatry, need medical intervention, and it's that concept, right? If we do all of that right from top to bottom of the tiers, we don't have to have exclusion criteria because we're using our resources better, and because we've designed our system to be able to respond to all levels of need across a continuum. So the people who have really mild kinds of needs, well, they can still be seen, but it's probably going to be one session. It might be just that they come to a skill-building group for a few months. It might be something that's really not expensive, not hard to deliver, because these are not clients who are in great need. They're just people who need to learn some skills or feel some support. So the type of service matters, and private systems, private practices have complete flexibility around this issue, and so I'm going to get to the positive and the negative on that. They have complete flexibility because if you're a private practitioner, you have your own business, you can choose to accept anybody you want as a customer of your business. Okay, so as a client, and I'm not trying to over corporatize it. I'm just saying you can choose to take anybody you want, even if it's just somebody who literally just wants somebody to talk to. They can pay you to talk to them, to be their friends, kind of, and not really have major problems to deal with. So really, access is way better in some ways in the private sector when it comes to this issue between mental health and mental illness. But the trouble we have is that we are living with a two-tiered system, right? So if you're a private practitioner, you're, at least in Nova Scotia and some other provinces, I don't know if there are exceptions to this, but your services, if somebody comes to you, are not covered by the provincial health insurance the way all other health care is. So people either go and they wait, or they get excluded, or something nasty like that in the public system, or they have to pay privately out of their pocket if they don't have insurance for the private sector. So, this is another issue we need to correct. If we want to expand the availability of services, reduce the demand, provide service across the continuum from health to illness, we should be negotiating with our provincial governments about that issue of working out funding arrangements so that private practice mental health supports can be billed to the province for anybody that doesn't have third-party insurance. Another advocate job.
I'm realizing now that we're actually a minute away from an hour. And so, and the reality is that most social workers in Canada are not in private practice. There are a lot of them, but there's not the majority. So I will close with this big question, which is, as a social worker who works inside the system, how can I advocate for changes like these without losing my job?
Yeah. Well, there are creative ways to do that. Having spent a career walking on that tightrope and having gotten in trouble a few times for that kind of thing, you do have to be careful. So I would not ever recommend that you just go out with guns blazing. It is a tedious process, but it is important that you understand that there is a legal distinction between your rights as a citizen and your obligations as an employee. And the key thing is that you can't be publicly undermining the reputation or the work of your employer. That doesn't mean you can't be advocating for positive things. That's different than advocating against current negative things. Right, so being careful of that, and gathering other people, or joining existing causes, joining existing Facebook groups or advocacy groups, so that you're one of many, and you're never the spokesperson, but you're behind the scenes helping to build the arguments. There are lots of ways to do that. Build relationships with your bosses and start to try to insidiously drop hints about how things can be changed. Talk to your elected officials as a private citizen. Just meet with your own member of your provincial legislature. Meet with your own member of parliament as a private citizen. It's your business. It's your right. Nobody can stop you from doing that. That's not like screaming publicly, the system I work for sucks. So there are absolutely ways to do this. And if anybody's, I said at the last, since we're getting to the end, if anyone's looking for more information about some of these things, or if you see that in your area there's some need for any kind of presentations or coaching or consulting or support around these issues, this is what I do. So I'm available, and my email address is on my website, which you can see on the last slide. And so don't hesitate to contact me with questions, and I'll do my best to answer any questions you didn't get answered today, and I'll also do my best to put in a pitch for any opportunities that you might see to have me come to your area and speak at a conference, a workshop, or do some consulting with your programs or provinces or whatever. This is, just to give you a sort of tiny background for 1 second, Sally, and then I'll let you have it. I wrote this book that for a reason, and that reason is that I firmly believe, and this is the social worker in me, I firmly believe that we are dealing with an oppressed population. The people who are suffering from all levels of mental illness and addiction-related problems, I believe they're an oppressed population that are discriminated against and experiencing prejudice on a daily basis, and I believe that it's the evolution of our system, because it was never really designed. It just evolved from many decades ago. It's the evolution of the system that causes that oppression, and I believe that they needed a voice, and that's why I wrote this book as a guide for how to make the system actually be about the client, to empower them, to give them what they need, not what we think they need or not what we need. Anyway, so I'm available. Just check out my website. Email me anytime for anything I can do.
Well, I think definitely the listeners will really appreciate that, Todd. And I have to thank you again for lending your time and expertise. Again, for everybody in the audience, the next webinar in the series is scheduled for August 2nd at 12 p.m. Eastern Time. Again, thank you everyone for joining us today. I apologize if we weren't able to get to your questions due to the time constraints. As a reminder, this is going to be posted on the CSW website as well as on our YouTube channel in the near future. Of course, for those of you who attended 45 minutes or more of the presentation, that certificate or that confirmation of attendance can be downloaded by clicking the yellow icon. It's the rightmost icon at the bottom of your presentation window. Some of you have been saying it hasn't popped up for you yet. If right after we're done talking you press refresh on your browser, it will pop up for you. So hopefully that works. Again, thank you in advance for taking a few minutes to complete the short survey that's going to be prompted when you exit the window here. It will help us design future continuing education opportunities. So with that, I do have to say a huge thanks again to Todd for his time and expertise. And with that, have a great afternoon, everyone.
And spread the word about next week's session. You still on there, Sally?